He may even identify himself with it and believe that he is what he appears to be.
Welcome to the NCE Study Guide. Today is July 15th, 2025, and we're about to embark on a deep dive into some really crucial concepts for your counseling journey. We're specifically focusing on differential diagnosis today. And actually, this whole module came about from a fantastic study group discussion. So a huge shout out to Angela and Janet for planting the seeds for this. Our mission really is to unpack the subtleties of diagnosis, not just the what, but the why and the how it impacts clinical practice. And of course, your exam preparation. We'll start by immersing ourselves in a practical case study that brings these concepts to life.
Yeah, and what's fascinating here is how often these theoretical concepts and diagnoses suddenly become incredibly clear when you see them through a real-world lens. This deep dive should really help you connect those dots, between symptoms, diagnostic criteria, and that critical thinking you need for effective counseling.
Okay, let's unpack this with our first scenario. We're calling the section the intake maze. So picture Angela. She's a graduate intern shadowing an intake clinician. They have a new client, Bree, who's 22, a college student. Bree's presenting with, well, pretty classic stuff. Sadness, fatigue, difficulty concentrating, and insomnia. So the clinician's working diagnosis is major depressive disorder, MDD. It makes sense, right? But here's where it gets really interesting. Angela's intuition kicks in. She remembers Bree recently lost her sister maybe just a month ago. And she starts wondering, could this be prolonged grief disorder instead? She flags this for her supervisor.
That's a really insightful observation from Angela. It perfectly illustrates a few core concepts. Major depressive disorder is definitely on the table with those symptoms. But Angela bringing up prolonged grief disorder is key. And it's important to remember PGD was only added in the DSM-5-TR back in 2022. It's relatively new. It recognizes that sometimes grief is just unusually persistent and debilitating, different from typical bereavement or MDD. And this whole process Angela's going through, considering multiple possibilities, that's differential diagnosis. You have to look beyond the obvious, consider lookalikes. It's critical thinking in action.
Right. And that leads directly into the next challenge Angela faced, which we'll call 2 weeks or 2 years.
Yeah.
She's in supervision, asking about the duration criteria, MDD versus persistent depressive disorder, PDD. What's the difference?
Ah, yes. This is a classic NCE distinction. It's all about the timeline. For major depressive disorder, those core symptoms need to be present for at least 2 weeks. Persistent depressive disorder, though, that's a longer haul. The symptoms need to have lasted for 2 years. It's a major difference in chronicity.
2 years. Okay. And sometimes a little mnemonic helps lock these things in, right? We came up with one. 2 weeks to feel blue, 2 years to drag through.
That's actually pretty good. It really highlights the importance of timeline criteria in diagnosis. It's often the deciding factor.
Okay, let's shift gears slightly to anxiety. Angela encountered this in another case review. The anxiety umbrella. She's looking at a file. Client reports panic attacks, excessive worry, lots of tension. The previous clinician noted generalized anxiety disorder, GAD. But Angela's thinking, maybe panic disorder fits better.
Another great example of teasing things apart, GAD. Well, that's more like a constant hum of worry, right? It's persistent, broad, across lots of different areas. Panic disorder, on the other hand, is really defined by those distinct episodes, those sudden, intense surges of fear, the panic attacks. There might be worry between attacks, sure, but the core feature is the attacks themselves. So you really need to compare the diagnostic criteria carefully. Is the primary issue the pervasive worry or the episodic panic?
Now let's bring in Janet, another intern, with the scenario we're calling diagnosing from a distance. Janet observes that clients often come in already having diagnoses from previous providers. Happens all the time. She's curious about things like bipolar spectrum disorders and borderline personality disorder, BPD. But she feels hesitant, maybe even a bit intimidated, to use those labels herself.
And that hesitation is understandable, and frankly, quite appropriate for an intern. This touches on some really big issues. Diagnostic stigma, for one. Some labels, fairly or unfairly, carry a lot of weight and potential misunderstanding. Then there's scope of practice. As counselors, we need to be clear on what we are competent to diagnose and when referral or consultation is necessary. And that leads to diagnostic humility. Knowing your limits, consulting supervisors, especially with complex diagnoses like bipolar or BPD, is crucial. Just briefly, bipolar I involves mania, those periods of really elevated mood and energy, often impairing function. Bipolar II involves hypomania less severe, plus depression. And BPD involves that pattern of instability in relationships, self-image, emotions, and impulsivity. Complex stuff. Requires careful assessment.
Okay, one last scene from the intern files. Labels and insurance. The team is discussing why certain codes, specifically Z codes, they used to be called V codes, why aren't they reimbursed by insurance? Angela points out correctly that these codes are for psychosocial issues, things impacting health, but not actual mental disorders.
Exactly. This is a super practical point. Z codes are clinically valuable. Absolutely. They capture things like homelessness, relationship problems, economic stress, crucial context. But they are not billable mental health diagnoses for insurance reimbursement purposes. Insurers typically reimburse for F codes, which represent the diagnosable mental disorders in the DSM linked to the ICD system. So there's this distinction between what's clinically relevant, captured by Z codes sometimes, and what's a reimbursable diagnosis, usually an F code. It's the reality of clinical versus reimbursable diagnosis.
Okay, so we've seen these interns grapple with diagnosis. Let's pull back. What does this all mean for you, the listener, the learner? Why is this concept of diagnosis and differential considerations so vital?
Well, fundamentally, getting the diagnosis right drives everything else. Your treatment plan, the interventions you choose, ethical care, even getting paid. A misdiagnosis can lead down the wrong path. Ineffective treatment, maybe even harmful treatment, if you miss something serious or treat the wrong thing. Differential diagnosis forces you to be systematic, to consider alternatives, to rule things out, and importantly, to know when you need to consult. It protects the client and you.
And connecting this to the bigger picture, understanding a bit of the history helps, right? How did we even get these diagnostic manuals?
It's definitely not static. The first DSM came out way back in 1952 from the APA, but a really huge shift was DSM-3 in 1980. That's when they introduced specific, operationalized diagnostic criteria, like checklists almost, made diagnosis much more reliable, more consistent between clinicians, a game changer. Then DSM-5 in 2013 brought major reorganization, got rid of the old multi-axis system, added new disorders, and the latest, DSM-5-TR in 2022, put more emphasis on cultural formulation, clinical judgment, and, as we mentioned, added prolonged grief disorder. It keeps evolving.
So if we were to break it down really simply, how should someone think about the process of diagnosis?
I like the detective work metaphor. You're gathering clues, the client's symptoms, you're collecting their story through the clinical interview, you're checking evidence, maybe using screeners like the PHQ-9 for depression severity, you're ruling out red herrings, those disorders that seem similar but don't quite fit. And crucially, you're consulting colleagues or supervisors, bringing in another detective for a fresh set of eyes.
Okay, the million-dollar question then. How might the NCE test you on this? What should you expect?
Definitely expect scenario-based questions, vignettes. They want to see if you can apply the knowledge, not just list criteria. So you might get a brief description. Client shows irritability, high energy, risky behavior for a week. What's the most likely diagnosis? You'd need to think bipolar I, perhaps. The key is knowing those broad distinctions we've talked about. GAD versus panic, MDD versus PDD, by IMDD versus 2. And understanding Z codes versus F codes. They love testing those differentiating factors.
Let's hammer down some of those key clinical decision points again, those common forks in the road.
Absolutely. Let's do a quick rundown. MDD versus grief. Is the sadness a normative response to loss, or has it become pervasive, debilitating, meeting MDD criteria? That's the core question. Bipolar I versus 2. The absolute key is, has there ever been a full manic episode? If yes, it's bipolar I, even if they mostly present with depression now. If only hypomania and depression, think bipolar II, GAD versus panic disorder. Is the main issue pervasive, chronic worry, GAD, or distinct sudden panic attacks, panic disorder, Z code versus F code? Is this a psychosocial stressor or life circumstance impacting health, Z code, or a diagnosable mental disorder with specific criteria, F code?
Got it. And are there common subtypes or related models within these broader categories we should keep in mind?
Yes, definitely. For the bipolar spectrum, beyond I and II, remember cyclothymia, that's chronic, fluctuating mood instability, but not meeting full criteria for mania or major depression. Milder, but persistent swings. With grief versus depression, the focus is key. Grief is usually focused on the loss. Depression tends to be more global, pervasive low mood and loss of interest. And for conduct disorders in youth, knowing the onset matters. Childhood onset, before 10, adolescent onset after 10, and that life course persistent type we mentioned, which suggests a more ingrained pattern starting early and continuing. Okay, time for some practical tips. How can you nail this down for the exam? Retention strategies. Mnemonics help, like your 2 weeks equals MDD, 2 years equals PDD. Commit that one to memory. Also, using practice question apps, Momentrix, DSM-5 flashcard apps, they give you lots of scenarios to work through. Repetition helps. Studying with a partner is great. Quiz each other. Explaining it out loud really solidifies it. And I'm a visual person. Creating simple flowcharts or timelines comparing disorders side by side can make those distinctions much clearer.
So, boiling it all down, what are the absolute must-knows from this deep dive?
Okay, key takeaways.
Yeah.
The DSM-5 organizes by symptom clusters and duration. You need to know how to differentiate look-alike disorders, focus on those key distinctions. Understand Z codes are clinically useful for context, but not usually reimbursable. F codes are for the disorders themselves. And critically, always stay within your scope of practice and consult when you're unsure. Diagnostic humility is essential.
All right, let's see how well you've absorbed this. Time for a quick NCE-style mini-quiz. We'll go through each question, I'll give you the options, restate the question, and then we'll break down the answer. Ready?
Let's do it.
Question 1. A 23-year-old client reports sadness, poor appetite, and insomnia for 10 days. She lost her grandmother a month ago. What diagnosis best fits the presentation? Okay, your options are A, persistent depressive disorder, B, prolonged grief disorder, C, major depressive disorder, D, cyclothemic disorder. So again, sadness, poor appetite, insomnia for 10 days following the loss of her grandmother a month ago. What diagnosis best fits?
The correct answer is C, major depressive disorder. Here's why. Grief is definitely present, but the symptoms described meet the criteria threshold for MDD, which requires symptoms for at least 2 weeks. Even though she's only reported them for 10 days, the type and severity fit MDD, and the 2-week duration for diagnosis is met. Prolonged grief disorder requires symptoms to be present much longer, typically at least 12 months post-loss for adults, and the focus of the distress is specifically the grief itself being prolonged and impairing. PDD requires 2 years. Cyclothemia involves mood swings, so MDD is the best fit here based on the criteria presented.
Makes sense. Okay, question 2. A client experiences frequent worry across many domains and muscle tension for over 6 months. What diagnosis is most likely? Your options. A, panic disorder, B, acute stress disorder, C, generalized anxiety disorder, D, adjustment disorder. So, frequent worry, many domains, muscle tension over 6 months, most likely diagnosis.
The correct answer is C, generalized anxiety disorder. The key giveaways here are frequent worry across many domains and the duration over 6 months. That's classic GAD, pervasive, excessive worry, hard to control, lasting at least 6 months, often with physical symptoms like muscle tension. Panic disorder is about recurrent panic attacks. Acute stress disorder is trauma-related and shorter duration. Adjustment disorder involves distress following a specific stressor, but doesn't usually fit this pervasive worry pattern.
Got it. Question 3, focusing on ethics. A counselor is hesitant to diagnose borderline personality disorder due to its stigma. What is the most ethical action? Options. A, use another diagnosis instead. B, consult with his supervisor before proceeding. C, avoid documenting it. D, ask the client if they accept the label. Most ethical action when hesitant about diagnosing BPD due to stigma.
The answer is B. Consult with his supervisor before proceeding. This is non-negotiable, ethically. Diagnoses like BPD require careful consideration due to complexity and potential stigma. Consulting ensures accuracy, objectivity, and helps you plan how to discuss it therapeutically with the client if it is the correct diagnosis. Using another diagnosis, A, is inaccurate and unethical. Avoiding documentation, C, is unethical and potentially harmful. Asking the client to accept the label, D, isn't the first ethical step. Confirmation and consultation come first.
Excellent point. Question 4, about childhood behavior. A child has been aggressive since age 7 and has not stopped into adolescence. What is the best description? Options. A, oppositional defiant disorder. B, life course persistent conduct disorder. C, intermittent explosive disorder. D, cyclothemic disorder. Aggression since age 7 continuing into adolescence. Best description.
The answer is B, life course persistent conduct disorder. This specific subtype points to that early onset, before age 10, in this case age 7, of significant aggressive or antisocial behavior that continues through adolescence, suggesting a persistent pattern. ODD involves negativity and defiance, but usually not the severe aggression of conduct disorder. Intermittent explosive disorder involves discrete outbursts. Cyclothemia is a mood disorder. The persistence since childhood is key here.
Okay, final question number 5, testing those code types. Which diagnosis code type reflects psychosocial issues not classified as mental disorders? Your options: AZ code, BF code, CT code, DB code. Code type for psychosocial issues, not mental disorders.
The correct answer is AZ code. As we discussed, Z codes, formerly V codes, are used in the ICD system and referenced in the DSM to note conditions or circumstances that affect health status or contact with health services, but aren't mental disorders themselves. Think housing problems, unemployment, relationship distress, etc. F codes generally correspond to the diagnosable mental and behavioral disorders in the DSM-CD.
T codes and B codes aren't the primary categories for this purpose in this context.
Fantastic walkthrough. Okay, before we wrap up, any last-minute bonus strategies for tackling these kinds of diagnosis questions on the NCE?
Yeah, a few quick ones. First, always look for timelines in the question stem. Is it days, weeks, months, years? That often rules options in or out. Second, spot those keywords. Words like episodic, chronic, pervasive, sudden, recurrent, they point towards specific diagnostic features. Third, definitely use the process of elimination. If you can confidently rule out 2 options, your odds on the remaining ones are much better. And finally, always ask yourself, does this fit the full picture? Don't get anchored on one symptom. Consider the whole presentation described in the vignette. Think like that diagnostic detective.
Great advice. Remember, you're not just memorizing facts for an exam here. You're really learning to think like a clinician. You're learning to sift through those threads of thought and understand the subtleties of diagnosis. Keep going. You're closer than you think.
Absolutely. The goal is clarity in your assessment, collaboration with supervisors and clients, and ultimately providing the best possible care. That ability to differentiate diagnoses, understand what they mean, and know when to seek help, that's invaluable.
And if you found this deep dive valuable today, please consider giving us a 5-star rating wherever you get your audio. It really does help us reach more learners like you. And if you want to join a great community and get access to more study modules, think about joining our study group via Patreon. Your support is what keeps these deep dives going. Until next time, keep exploring, keep learning, and keep growing.
1, 2, 3.
Nice to be in orbit.